Thanks, Anne, and it's good to be here. It's good to listen to the previous talks too, and I don't think I've, in so many talks, heard so much I disagreed with for quite a long time. So that might help to get the aggro going a bit. As he said, my background is of a physician. Actually, I've done lipid clinics and diabetes clinics and obesity clinics over the years, although I'm now retired from the health service. So I have seen, I don't know how many thousands of people, often recurrently, and I can confirm that it is correct there that I have, in terms of managing them from the lifestyle point of view, been to a large extent a complete failure. And that's what this talk's about, really. Is there any understanding to come from that? Having said that, it's also not quite true. I've not been a complete failure, and you'll forgive me for family photographs. This is Debbie, who's a family doctor up in Leeds. On the right there, the orange hair, is Jonathan, who's professor of physics in Switzerland, in Zurich, and clearly they don't fall into your category of being at risk of diabetes, obesity, and indeed it cascades down, doesn't it, to the grandkids, as you can see. And of course, the reason for the success in the prevention of those problems comes down to their environment when they were younger. And we can discuss that would be. Debbie was quite embarrassed at school because on the age-weight graphs, she was always an outlier. And that too has quite considerable cultural significance for where we go. Of course, it's not just true that you can achieve these things in England, in the north of England. It's about 300 miles away, for those of you who don't know Newcastle. This is Toraja in Sulawesi, Indonesia. And there too, they don't, amongst this population who, as you can see, are still rice growers for the most part, have an obesity problem. Of course, they have the infectious diseases problem. And of course, it's pretty obvious why TB is associated with this kind of lifestyle rather than being more overweight. But in practice, if the culture is right and these people aren't unhealthy, then obesity, meta-obesity, diabetes and the like are not there. Diabetes in this population, about 0.5% to 1% within their lifetime, and they live to be quite old. It's a different kind of type 2 diabetes which develops. It's also not true that this is a new phenomenon, and certainly what's this, 1500 years ago, Paul, who I hate to say it was a surgeon, was actually writing about the management of obesity in Greece in that time. And you'll see that the basic ideas were well understood, even if this isn't really a guideline. It's a classical textbooks, include such things as melting the fat down, active exercises, tenuant regimens at the bottom. It's rather good, isn't it? A smaller quality of food ought to be given in proportion to the exercise taken. My dietitians would disagree with the last statement. I have to say, it is true, and how I dealt with breakfast this morning, as I do at conferences, was not to have it, because I know that at lunchtime I will eat about twice as many calories as I would at home. So we have some other ideas too for diabetes, similar kind of approaches. Again, this from a long time ago. Can diabetes and obesity be prevented? Fundamentally, it's a very simple question. And of course, they have increased dramatically over recent decades. And that, therefore, must, of course, be due to the changing environment. And I use that word in its widest term. An environment is modifiable, although it may be actually difficult to do it. That conclusion applies to populations, and where I've been unsuccessful, of course, my practice is applying that to individuals. Why is that? Well, I think it's clear that individuals are programmed by their prior experience. And it does not then follow that any particular individual can change. I'm talking about adults. And this accounts for the frustrations, the terrible frustrations we feel in our partnership with our patients over this time. Can you imagine seeing the same person every 3 months, 6 months for the same problem and not being able to make progress with it? It really is quite disheartening in many ways. The culture is easily shown in a couple of comments. Somebody already commented on the last part, that we are great fans of sport, but we don't take part in it. We watch it. Here, a great Australian sitting in his chair, drinking a beer, watching television, very much the culture that a lot of people follow in a lot of the world. Perhaps the beer isn't there in the Gulf countries, but the obesity is horrendous. And sitting in front of the television eating dates is certainly one of the biggest problems. And if you've got a dog, you walk it on a treadmill, it appears. That's a little bit apocryphal, but it makes the point. We've got the point in our culture where it's also not correct to actually use slim people any longer. Somehow the problems of eating disorders have actually caused us to worry that having a BMI of 18 to 20 is somehow abnormal. And I can tell you it's not abnormal. It's common and usual, and people are healthy with it, but it's no longer appropriate. And a major bank here, when advertising, feels it is appropriate to put obese children in its adverts as in the central part. So our culture very much in this country, certainly in Australia and North America, has switched that way. In the last couple of weeks, I've been in Lisbon, I've been in Croatia, and I can tell you that it's not true there. We still have lots of people who culturally expect and dress to be relatively slim. And it's no wonder life expectancy in those countries which have been hit since 2005 as regards the economic crisis have increasing life expectancy, whereas life expectancy has stalled in the UK and stalled in Germany. We've been predicting that for 15 years. How did we say it? We're seeing generations who are not going to live as long as their parents did. This slide you've seen already. I see actually my attribution is right. It should be cdc.gov, of course. But some people will say that we're beginning to conquer the problem, and we're not. Clearly, obesity continuing to rise there in adults and, disappointingly, in youngsters in the US. I have to say, talking to people in clinics, one does understand there has been a cultural change. It occurred somewhere around 10 years ago that people began to understand that to be normal weight was a good thing. But sadly, it infected in different parts of the community, and notably those people who are better off rather than those people who are poorer. And I'll come back to that point later on. So eating behaviour, I think, is programmed during childhood by food type and availability, and I'll show a couple of examples. By parental expectations. So should we be changing parents? And by psychological influences. Frankly, after childhood, individuals find it difficult to reprogram themselves. Simple actions may be important. Mike Huckabee who was a Republican candidate at one stage and governor, I think, of Arkansas, told me that he coped with his diabetes initially simply because he was drinking too much cola and sugar and simply had to cut that out with high sugar foods. But other more complex things are much more difficult to do, and usually are frustrating failures. And I come from a university which has a big successful physical exercise unit attached to its diabetes unit. This appeared, it appeared on Medscape, you can see this month, in fact, from a doctor. So an educated man, and you can see in here a man who gains self-esteem for what he does. Calories in, calories out, exercise more. The good news is it works. But he says it works only as long as you're completely obsessed with it. So this doctor actually had to apply considerable personal psychological pressure to himself to succeed. 1,200 calories a day, running 6 miles a day. The weight came off dramatically. But the minute I went away from my total focus, other things, ordinary life things, interfered with the meticulous calorie counting, and all the weight come back. And then, of course, you have the failure and you lose your self-esteem and you become disheartened and it becomes even more difficult. This is not untypical, except that few people actually have that degree of success in the first place. This is from my own practice. You may say it's anecdotal, but a cohort of ladies I was seeing with fairly extreme obesity for those days, BMIs of around 40 or higher, often diabetes, I became aware that there was a common thread in a lot of them. And the common thread, when I teased it out gently as we got to know each other, was about 50% revealed a history of childhood sexual or physical abuse, managed and in youth by comfort eating. So we uncovered that. We referred them to psychologists, and they came back reporting just how useful it was to talk to psychologists about their problem. But it had no impact on their eating behaviours. They were programmed, and they couldn't change. And by the way, I'm not saying that 50% of people with BMI now of 40 have these kind of problems, but they do tell you that eating habits once ingrained are not easily changeable, even with professional medical and psychological help. Can physical exercise help? A rule of thumb is that about 100 kilocalories per mile are burnt for an 82 kilogram person, but most of my middle-aged overweight people really could not realistically, and perhaps I should say will not, manage walking more than 30 minutes a day. They rarely achieve this, and indeed if they do, their pace, you only have to go to a shopping centre, is way below that where they would get a mile in. This would be the context of a calorie assumption in the obese, perhaps 3,000 calories a day, and you can see that the effect, even if they are successful, is to leave them about 3 kilograms lighter at 79 kilograms. Getting beyond that is just not realistic. This is another of the problems that occurs, and perhaps worth careful explanation. These are people given a very low-calorie diet, 200 calories a day. And when you do this, what happens, and this is a typical person, is you get a very rapid drop in weight. And you read about it in the newspapers, don't you? I lost 7 pounds in 1 week. It's nonsense. It's not actually possible in terms of physics. And the problem is, of course, you get fluid retention with obesity, or rather fluid retention with excess calorie consumption, and you get an early fluid loss. You then get a disheartening phase. nearly always for a week or two, weight flattens out again if you try extreme dieting before you get on the steady state loss corresponding to about 7,500 calories per kilogram, which allows you to come off. But notice that 5 kilograms here, 5 BMI here occurring, taking about a month, and this is on a very low calorie diet. It's not maintainable. It wasn't maintained in this group, and it's not something that's worth doing. In diabetes, type 2 diabetes is not due to obesity. Please do not say that. It's due to excess calorie consumption in these people. If you cut their calories from eating within 1 week, glucose normalizes, demonstrated here in this old paper in the journal Diabetes. I think these were possibly prisoners in the days you could study such people, but it's been looked at in more detail recently by my colleague Roy Taylor in Newcastle. Here you can see, again, people with diabetes given a low-calorie diet. You can see fasting glucose normalizing in 1 week. And of course, they're still obese. And of course, they still have a fatty liver as well at 1 week. Those go on declining because the calorie consumption is the same, the glucose remains the same. So here we're talking about calorie toxicity, and it's really calorie toxicity which is the basis of metabesity, NASH, all the other things rather than anything else. It goes back, by the way, about 3 billion years to early food regulation by bacteria, but the pathways are for discussion on another occasion. It's not always true that I can prevent diabetes by getting people, even if it was possible, to change their eating. Some, of course, do have other problems, notably in the elderly and thinner patients. You have people who don't have fatty liver, and it's fatty liver that's the basis of the metabolic problem. You can see the ALTs are down normal. They have normal triglycerides because that's produced in the liver, and no insulin resistance. So there are also a group of people in whom you cannot put the diabetes into remission with calorie change because they have a different phenotype, but they are the minority. And we're really talking about this group who respond well to calorie control if you can do it. A slide was put up earlier looking at metformin and lifestyle, a prevention of diabetes, and the comment was made it wasn't very effective. It's important to notice here that you get these amazing reductions early on in relative risk. Here 60%, and I don't want to say too much further before I talk later today, but actually what this is a delay of 1 year. It's a delay of 1 year in people who are perhaps aged 40 or something of that order, and in healthcare terms, this is not, frankly, terribly useful. So a lot of the statistics concerned with prevention are based on relative risks and hazard ratios in very early times of the study. If you look at them, then the separation of the two curves remains at 1, sometimes 2 years. This is not realistic to expect drugs to do this. We would never, of course, think of giving a thiazolidine anyway to people who didn't have diabetes or NASH. Then we have other drugs. Can I achieve it with other drugs? Well, this just makes the point that actually this is exenatide, perhaps one of the better ones. You're getting, what's that, 4 kilograms off perhaps only 3 kilograms if you subtract the placebo effects. So none, as was said earlier, of the medical approaches is successful. And it's worth asking just why that is actually. Why is weight so limited with these agents, which really are quite potent? And probably the answer is we have feedback mechanisms within us, particularly hypothalamic, perhaps a gut, which take us back towards our programmed weight. So the drugs try and drive it out, but self tends to drive it back. And this will involve other gut peptides such as PYY and ghrelin. And I do perhaps have the impression, Michael could know more about this than I do, that combination peptide approaches might actually be more successful, perhaps akin to those of bariatric surgery. We can work out some of that to illustrate it. Somebody, was it Zan, put up an empagliflozin slide earlier. It's an SGLT2 blocker. These drugs cause you to lose sugar through your urine, to pee it out, as it were. It's around 80 grams per day they achieve. It implies a calorie balance negative of 300 to 400 calories per day, which should cut your body weight by 8 kilograms. And the physics goes wrong. It actually, they achieve a weight loss of about 3 kilograms, sometimes not even that. And what's happening, and you can demonstrate this, is that unconsciously people actually, given these drugs, eat more to restore their calorie balance. So we really are badly programmed, and we have to, if we're going to achieve anything in the metabolic medical area, we have to interfere with those feedback behavioral mechanisms. Just to upset a few more people, I spotted a few other things. This comes from designing interventions to change eating behaviors. Again, it's a comparatively recent publication. There's this wheel of change with regulation, service provision, legislation, guidelines, a whole range of things on this. And within the paper, there's a couple of equally complex table of multiple interventions. And as soon as I see anything like this in medicine, I know something. What I know is that they haven't found the solution to the problem. And of course, it's characterized and well known from the amphibians. This is the midwife toad with the eggs carried on its back. But if you actually look at frogs and toads, they failed to solve the problem of how to look after your eggs. And they came up with a huge variety, there are probably others, of doing this. And of course, the solution was to wrap it up in a shell and sit on it. Or to incubate your fetus internally. But the amphibians didn't solve it, so they come up with multiple approaches to it. I'm getting to the end, but I also couldn't resist seeing this highlighted in The Economist, again within the last month, about food taxation and subsidy and perverse effects. And it's particularly interesting because the perverse effects are particularly in those people who need help most, i.e. the less well-resourced. So fat taxes, and this is an experimental study, that's its weakness, done in France. Women in poor incomes ended up paying disproportionately more for their food due to the taxes, so they became poorer. They then changed their habits less than people who were well off, but continued to buy the food they liked rather than food of quality. The poor, because poorer if tax is directed to the food they eat most. By contrast with subsidies, the story wasn't good either. All income groups did buy more, but the well-off people actually bought less of more, if you like. The poor, in fact, tended to use the savings they had to buy more low-quality foods. So you can't win, and the taxation thing, although I believe it can be useful under some circumstances, is not as simple as it might seem. Conclusion, ladies and gentlemen, in general, in clinical practice, yes, I have been a miserable, I use that word slightly intentionally, failure in this regard. Beyond the first 3 months after diagnosis, a heart attack, diagnosis of diabetes can make a big impact for about 3 months, and people can hold some change then indefinitely, but they can't improve further. This, I believe, is largely due to childhood programming of calorie balance, and there I'll just emphasize that what I've said we're talking about is not metabesity. Let's call it calorie toxicity, can we? Accordingly, individual and population initiatives in adults will be largely unsuccessful. Cultural change is needed, but is tricky and slow. Targeting initiatives to school-aged children, I believe, makes a lot more sense, not least because they influence their parents. You can watch that happening, but also because within a short period of time, they will be the parents of the next generation, and they have to learn how to feed their 6-month to 1-year-olds properly, as well as later on in childhood. And lastly, in terms of medications, bariatric surgery suggests that it is possible a medical intervention can be successful in time, but as yes, we do not have access to widely approvable technologies in the medication field. There is some promise. I thank you for your attention.